So this is what I'm going to talk about, are the treatment options. So medical therapy, I've already told you, is one option, and you can give them maximum tolerable medical therapy. They are young, you need to keep their IOPs low so that they can continue for the rest of their 40 to 60 years of their life. The laser trabeculoplasty is generally avoided, and in fact is considered to be contraindicated in these patients because doing a laser does not make any difference. A trabeculoplasty may only raise the intraocular pressure. You must understand that they've developed high pressures because of dysgenesis of their angle, and this has occurred at a young age, and there is a developmental dysgenesis, and the laser trabeculoplasty is not going to function in these patients. As far as the surgical outcomes, the surgical options are concerned, there are a lot of non-penetrating options, non-penetrating deep sclerectomies, gonioplasties, goniotomies, canaloplasties. Everything has been tried, even glaucoma drainage devices. But you must understand that trabeculectomy is the gold standard as far as the treatment of these patients is concerned. It is cost-effective and it can work for a very long period of time. Right? So therefore trabeculectomy should be given a choice, and as actually the choice of treatment, because they are presenting with very high intraocular pressure, severe visual field defects at some point of time, and therefore you need to have low pressures, which the non-penetrating surgeries will not be able to achieve. So therefore the next question is, when you're doing a trabeculectomy, are you going to do it with the mitomycin or without mitomycin? That is an important question, because application of mitomycin will have problems. These are the patients who are going to live for long, and this is a bit of a controversy whether to use mitomycin or not. Now, mitomycin is like a time bomb. You've applied mitomycin and it's going to stay in the patient's eye for the rest of his life. You see, the Tenon's capsule actually absorbs that mitomycin, and if you've applied mitomycin, these blebs tend to become avascular. Not that the non-mitomycin do not, but the incidence of avascular blebs, incidence of hypotony, incidence of low pressures is much higher with mitomycin than without mitomycin. So there is no randomized prospective study to compare mitomycin, and this was the only study that we are initiating, and this is undergoing in our center, where we are randomizing patients to mitomycin and without mitomycin. These patients are juvenile open angle glaucoma, and we found that mitomycin has low pressures, but if you have low pressures, you are also inducing cataract. Right? Low pressures will be associated with cataractogenesis, and again these patients have a long life to live. You see, so therefore if you are inducing low pressures and cataract, they'll have more problems, and blebitis and blood related infections. So therefore you have to be very judicious in using mitomycin, and my advice to you is, if you have to use mitomycin, use low dose mitomycin. Don't use high dose, don't use 0.4 milligrams per ml. This is contrary to what is being described in the West, that they are young patients, so you use more mitomycin. But this is not so. They are young patients, but that doesn't mean that you use more mitomycin. If you have to use mitomycin, use low dose. In our population, even without mitomycin, the results are as good as without mitomycin. And these are blebs. This is one eye of the patient that has been operated with mitomycin, the other eye without mitomycin. And more or less the IOPs are almost the same. The blebs are not very different. And you can see that over a long period, this is almost like 5 years down the line, the differences are not very significant between using mitomycin and no mitomycin. So what is going to happen once they are on treatment? What are the long-term structural and functional? What is going to happen with their progression of the disease? We found that once you treat these patients, 10% still go on to progress. They become worse, and the visual fields and the optic disc just undergoes progression. And the reasons why this is happening is probably genetic, because about a tenth of these patients have some problems whereby their IOP does not just get controlled with medical or surgical therapy. The rest of them do pretty well, and their intraocular pressure as well as the disease stabilizes. You have to follow up these patients for a very long time. Unlike what are the studies given in the West regarding adult glaucomas, where their glaucomas start at 70 years of age. Our glaucomas start starting at about 20 to 40 years of age. So therefore, they have a long life to live with glaucoma, and the question is, how many of them and what is the kind of progression they are going to get. And what we have seen is that again, a lot of them remain stable. That means over a period of time, you can even predict how their progression is going to happen. And this is what is used to this is known as a visual field index, which is used to show how the disease is going to progress over the next 5 or the rest of the patient's life. So you can see on the visual fields how the worsening is happening, and what is the rate of this worsening, and how this worsening is going to change over a period of time, and you can predict whether the patient will go perimetrically blind or not. right? So this is the visual field index, which extrapolates the patient's visual field over the rest of his life. And if he's young, this is all the more important that this be done. There are some patients who are moderate progressors. There are some patients who are very fast progressors. That means their visual field deteriorates much fast no matter what you do. You are doing a medical therapy, putting them through surgery, and then adding medical therapy, and yet they just go on getting worse, and you just don't know what to do with them. So there is about 10% of such patients who are progressing despite your maximum tolerable medical therapy and despite whatever surgery. And the risk of perimetric blindness in these patients. So the risk of perimetric blindness, if you take into account all these juvenile glaucomas, at least 10% over their lifetime are likely to go bilaterally blind despite your treatment. So these are treated patients which are likely to go blind over their lifetime. About 30% are likely of these eyes are likely to lose about 50% of the visual field. About 20% of these are likely to lose 100% of their visual field. And as I said, 10% are likely to go bilaterally blind perimetrically over their lifetime. And if you compare different diseases with juvenile glaucomas, if you compare primary adult open-angle glaucomas, angle closure glaucomas, if you compare it with pseudoexfoliation glaucomas, somehow the progression rates that we have calculated are not as high as in adult glaucomas. And the reason why it is so in juvenile glaucomas is there is some amount of reversibility. That means you lower their pressures, you do the surgery or give them a medical therapy, a large amount of cupping and RNFL loss can be reversed. So the younger the patient, you are able to achieve that. So on an average, their rates of progression are not as fast as are with the other diseases, which is good because they are young and if you treat them early, these are the kinds of patients you can save. Their visual loss you can save. And if you look at primary angle closure glaucoma and primary open angle glaucoma, these are adult patients. They have got other systemic problems. And also, you must understand that the juvenile glaucomas generally have a greater retinal ganglion cell reserve, right? They have greater RNFL reserve. So therefore, they are at a much less risk of blindness and compared to what has been described in many other studies. What about the visual impairment? Now, the kind of patients that come to us are generally in our hospital from a low socioeconomic background. My hospital, the kind of we have is a tertiary care center. It's a government institution where generally most of the patients are from a lower socioeconomic blindness. And when they come to us, almost about 5% of them are already blind. Because they've not been diagnosed or because they've not been seen elsewhere. About 4 to 5% have got low vision, but majority of them do have good visual acuity. So these are the kind of patients that you can salvage, and these eyes you can, if you treat them early, you can sort of prevent them from going. And why is it that some patients are coming with more severe disease and the others are coming with less severe disease? One is the intraocular pressure. Of course, if the patient to begin with comes with very high intraocular pressure, he's likely to have a very severe disease. But it also has to do with the socioeconomic status. If the patient is from a lower socioeconomic status, the likelihood of him presenting with an advanced visual field defect with a more severe disease and with blindness are much higher. So it has to go with both ways. The clinical features as well as the socioeconomic or the socio-demographic factors both play into a role in understanding why some patients are presenting much more severe than the others. Another interesting study that we have published is the quality of life. So a lot has been talked about the quality of life of adult glaucoma patients, but unfortunately there is nothing about in what happens in young. So these are the patients who have got a long life to live. They have to live with their disease for about 40, 50, 60 years. And what is their quality of life? And unfortunately their quality of life, which we tried to assess, was much better off than adult glaucoma patients, despite the fact that their visual disability was almost the same as that of the adult. And the reason why probably was that these patients are more carefree, they are young, they don't understand a lot about their disease, or also because the social support systems are so good at this particular age when they are young. So they are not so much bothered about their disease compared to when they are old. But it has a caveat to it, because they are not so they're so carefree and probably not so much involved in their disease, so their compliance might also be poorer, which again has to be taken into account when you are treating these patients. So you have to be very careful, and my suggestion is always give them booklets. All these patients, especially if they're young, tell them to go through them. I mean, a lot of them are educated these days. If they're presenting at young, they are able to read, they understand their disease, and then the likelihood of compliance will be much more. So give them those booklets. There are lots of these glaucoma pamphlets all over the place these days, and so you can just give them one of them that they can understand, and let them go home and read them, understand their disease, and then they come back to it, and their compliance increases all through their life, rather than just tell them that this is the treatment and then they go and they don't understand about their disease, and ultimately they go blind. So these are some important steps that you need to understand. So if I were to summarize all of these clinical and management features, there are a lot of things that remain unanswered. There are a lot of features which are common, a lot of features which are uncommon in these patients. Why is it that there are certain patients which are progressing much faster than the others? Why are there patients which are presenting with such high pressures, whereas the other juvenile glaucomas are not presenting with such? So therefore we do not have a proper classification. At the moment, all of them have been clubbed into one phenotype, which is 10 to 40 years of age group. Unfortunately, what we need is a proper genetic classification to find out which are the ones which are more severe, which are the ones which are less severe, and so we can then classify them that way. We do not have that. Another important is the inheritance. What is written in most of the books is that it is an autosomal dominant inheritance, which is again probably not true in our population, because a lot of them do have an autosomal recessive inheritance, and a lot of them are sporadic. That means there is no inheritance pattern in about 80% of the patients. So again, we need to look into this, and of course, as I said, the genes need to be seen, and the classification and a genetic association needs to be done to be able to fully understand the disease, and that is what we are also going. And finally, a lot needs to be done about what is the long-term treatment course with different therapies. I mean, at the moment, trabeculectomy is the only sort of surgical treatment, but we need to evolve more therapies whereby we can sort of manage patients who are just so refractory and don't do not get controlled so well. So over these years, over 10 years, last 10 years, these are the people that we have been working with in being able to understand this disease. And if there are any other centers who are associated, who want to be associated or want to work with us, we have a performa whereby we can sort of give you some clinical help and genetic help in being able to understand and collaborate with other centers, at least in India and even abroad, if anyone has a lot of juvenile glaucomas that they're managing. So with that, I would conclude this part of my talk, and again, if there are any questions regarding, yeah.